So we'll start this session right away. And I'm very happy to see Praveen and Gopal chairing with me. The essence of this session is basically nAMD, because nAMD, all of us have been managing from the time of lasers actually. And at that time, honestly, when I had just become a consultant in RP Center, we hardly had any treatments available. But today is an era of magic, I should say, that so many options are available. Hello, can we, Madhu, sit down or? So, and this era is of anti-VEGF. You see, even in this Congress, out of 532 sessions, there are more than double-digit numbers of anti-VEGF. And I'm sure Chaitra and all must be speaking anti-VEGF at least 3-4 sessions. One of the most sought-after speakers. So in any case, what I was going to say was, it's a fashion now. But the only thing is, you see, I did one talk where use and abuse also, because a lot of people indiscriminately also use. We will not talk about that. What we are going to talk is how it is evolving, because I like to classify VEGF into first generation, second generation. All of us started with Macugen. Macugen, I thought, was water only. There hardly any effect because the graph was always down. Then came ranibizumab, then aflibercept. And a lot of biosimilars are now coming up. So for the first time, graph started going up. Patients were so happy. And so now patients are happy. All these drugs are doing very well. The question is of compliance. Patients of compliance that they miss out. Once they improve, they will sit down. They may not come. You see, insurance penetration is not very high, so people have to pay. So just to avoid cost, by Dr. Saab ne bulaya, they will not go. You see, in US and other developed countries, somebody will ring you up, today is your day or tomorrow is your day for injection, please come. But here, no. So then is the need for longer duration acting agents. So therefore, drugs which can work for at least 3 months, 4 months, or, so that if a drug is given less often, compliance definitely improves, because he may not have to, not only injection per se is a psychological. You imagine yourself lying down and ek prick ja raha hai, or har mahine ja raha hai, so it becomes a difficult job. So hence is this role of this particular session that we talk, first talk is from drying to durability. Drying is good, but it has to be good duration also. So we have first speaker is from, it's a virtual, Dr. Chronopoulos. I have heard him before. Welcome, Dr. Chronopoulos. Can you hear us?
Yes, good morning. Yes, good morning. Can you hear me?
Yeah, I can. I hope you just listened to our introduction also. Were you there? Or?
Yes, I did. The host just let me in about 3 minutes ago. So yeah, I did hear your comments, yes.
Yeah.
I agree with them, yes.
So welcome, and we are all looking forward to your talk from one D to the other D also. You see, drying all these agents do, but the second generation of anti-VEGF, which have come in a very big way, are promising increased duration. So I will, like to start with your talk, which is drying to durability, deep dive into with brolucimab. Over to you.
Yes, many thanks, dear Dr. Werner, for the invitation. To all your colleagues there, I'm really honored to be again at your meeting. Can you see my presentation well or not?
Yeah, we can see and hear also. Yeah.
Okay, excellent. All right. So my title today is From Drying to Durability. As you said before, the drugs work, but they also need to give us a sustainable result. That's why I'm here to talk about today, the necessary disclaimer, as you can see. So when we're asking ourselves what's in the future and what do we need from the new drugs, we always think about having drugs, as you said, that they're more durable, that they work faster, and they can provide patients with a nice results for the next months with a stable vision and stable retina. And I always like to look at the path surveys that actually show what all the colleagues, not only in the USA, but also internationally, think and want for the treatment. And if you take a look, 2023, 2024, The major results, they don't differ that much. Most of the colics, they need a longer maintenance of dryness, and they need a better long-term visual outcomes. That's the same for 2023 and 2024. Why is that? Well, you know from the fact and from the practical experience that there is an unmet need, not only in AMD, but in other cases, but particularly in AMD, we have patients that are that are older, and we have adherence issues. We have a treatment burden that's unmet. We have suboptimal dosing, so it means the patient comes back in, we change the drug, etc. So all these things, they lead to a worse compliance, and at the end at the non-adherence. So all this sums up to a worse result for the patients. So we need a maximum sustainable vision with less injections if that would be possible. Is it so? Is it so from what we have seen so far from the registration trials and from the randomized controlled clinical trials in the real world? Yes, actually, that's the answer, because if you take a look here, this is a summary of all studies so far. In the right-hand side, we have the real-world evidence, and in the left-hand side, we have the randomized clinical trials, and we struggle to bring the left-hand side, the right-hand side to the left-hand side, where everything is controlled and we have a maximum result of the drug, whereas in the real world, we don't see the result. There are a couple of reasons for that, but this is the the reality so far. 3 years ago, we have since 3 years now, we have the third generation of anti-VEGF, and the one of the latest molecules that we have in our pipeline is the brolucizumab. It's on the right-hand side of this table. And if you see, this is a very extremely small molecule. These are only the single-chain antibody fragments of this antibody. It has a molecular weight of 26 kilodalton, which is extremely small, and this makes it easy for a higher molar concentration. And it was designed that way to penetrate the retina in a very efficient way. And we know from the Hawk and the Harrier studies, with work conducted for AMD patients, that the brolucizumab is drying the retina much faster than the comparator. We have better percentages as far as the macula is dry, and we have even less patients that have intraretinal fluid and subretinal fluid. If you take a look at these curves, the gray curve is a comparator, and the light and the darker blue curves are the the brolucizumab. You see how much smoother and faster the drug is drying the retina. And not only that, you don't have that much of volatility. I drew a red line to make it a little bit more understandable. You don't have that much of volatility in the retina, which is actually very good because you keep the tissue quite calm and dry. You have less fluctuations, and that's actually one of the things that we do really need. And has it paid off? Yes, it has. In the registration trial, you see that the darker curve, which is the highest, is the brolucizumab, and it reaches the desirable result in much faster way with less injections. That was as far as the registration trial is concerned. What about the real life? 2023, we saw this retrospective study, which was actually a registry analysis, and it gives us a first estimate of how this drug is working. And currently, at least 2023, the reality is such that it shows that the shift is towards the treat and extend, which means that we have now the option to a higher percentage of patients, it's almost 90% of patients, to extend the treatment plus 2 weeks, and almost a little bit more than half of the patients at this cohort, at this registry, they were extendable up to 4 weeks. And this is one of the things that these new drugs can really do. What comes from Germany? This is a study, the Blue Sky study. I'm not sure that you've heard of it, but this is a stress test, so to say, for the brolucizumab. This is actually the real world data as it shows in Germany. We had 542 patients with nAMD that were tested until the end of 2023. This was a 24-month trial, like 2 years. Currently, we have the interim data, which were 12 months. This was a prospective multi-center one-arm phase 4 study. And we included actually all of the patients. We included both treatment-naive patients and pre-treated patients. They had to have a certain history of pre-treatment with other drugs. but both treatment-naive and pre-treated patients, they were included in this study. Of course, the endpoints were evaluation of fluid reduction, anatomic effect, vision, and of course, ANEs. If you take a look here, both of the groups, the treatment-naive groups and the pre-treated groups, they were more or less similar. And basically, the indication, the pre-treatment groups that were a little bit higher, 61%, and the therapy treatment-naive were about 40%. Most of the patients, the pre-treatment group, they had a history of about plus 10 injections, more or less. And the reasons to switch, they were distributed amongst functional reasons, which means that the patient were not responding very well as far as the function is concerned. We had a vast majority of anatomical issues like IRF and SRF, things that we're struggling with every day. And some patients, about 26%, they wanted to extend the treatment intervals. So did it work? Yes, it did. It did. In the treatment-naive and in the pre-treated group, we had a robust reduction of the intraretinal fluid. You can take a look at these both graphs. Of course, the treatment-naive patients, they had a more robust reduction because they had no treatment before. The second group was the pre-treated ones. They also gained from the treatment a little bit lower because the eyes were pre-treated. This is as far as the intraretinal fluid is concerned, but exactly the same we saw in the groups in the subretinal fluid. There was a robust reduction of the fluid also in this parameter. What about the course of the CMT? And that's one of the things that's very, very important. You see, up to month 12, we had a stable reduction of the fluid. It speaks for a sustainability of the drug. What about the course of vision? You can take a look here. Depending on how the patients start the treatment, they also gain, and they gain sustainably. One of the most things that actually, for me, it's very important to see is that all of the groups and all the patients stratified in different groups, they do gain. But if you have somebody and you're thinking of starting the treatment or not, it's better to start fast because the patients that had a good vision from the beginning, they can maintain their vision up to 12 months. So it means that you don't hesitate. Start with a drug to have a good and sustainable result at the end. What about the sustainability and the flexibility of the treatment? Indeed, also in this area, there were major gains to see. As I said before, we had the treatment-naive and the pre-treated group. And one of the things that came out very nicely is the fact that the treatment-naive patients, they gained almost 25%. They went up almost up to 80%. The vast majority of this group, they could extend it they could actually be treated well with a treat and extend regime. And what does it practically mean? We had, for the treatment-naive groups, we have up to 12 months. We had 8 injections in 5 visits. And, sorry, the other way around. We had 3 injections at the beginning, and we have 3 injections at the end. We had 6 injections in 8 meetings. And the same, more or less, thing is also true for the pre-treated group. So we go down with the injections, and we also go down with the visits. Now, one of the most important things as far as brolucizumab is concerned, because there was a little bit drama at the beginning of the launch of the drug, is what's happening with the ANEs. And from this cohort of patients, we had a very small number of vasculitis and retinal vein occlusion. That was brolucizumab-associated ANEs. It was very interesting to see that also the other ones of the ANEs, there was also very low represented, which speaks actually for a very good tolerability of the drug. Now, we also did locally, we analyzed some patients. I don't really want to go into the details of the study. What I really want to show that the drug is really working. We had patients pre-treated and not pre-treated. It really works for the vision. It really works for the retina. But one of the things that really interested me from the beginning is take a look at this patient. This is a 58-year-old male patient with nAMD treated since 2026. Once we saw him in the consultation, we saw an extensive area of pigment epitheliopathy with subretinal fluid. It obviously hasn't responded to bevacizumab or sub-responded to bevacizumab, aflibercept. He also had a PDT in the past, and we opted to switch the patient to brolucizumab. And what you know, take a look at this area. The subretinal, the neovascular membrane goes away or gets very, very small, attenuated. And this is a very nice result. On the right-hand side, the subretinal fluid is gone after 3 injections of brolucizumab. There's one more interesting case of a patient that came in 2022. At that point, he had a very good vision. It was almost 100%. If you take a look, he has a very subtle alteration of the on the pigment epithelium, which could be at that point, which have been at that point a very premature nAMD. He came back 2 years later with a macular bleed. We treated him with corvitrectomy, TPA, and bevacizumab, and gas. And in the next course, he received bevacizumab on a monthly basis, and you see that the retina is not responding. Until we made the decision, it was mid of January 2025, to switch him over to brolucizumab, and take a look how he has evolved so far. This is a nice case that came right out of the consultation. You see how smoothly the retina goes down and how smooth the vascular membrane is getting smaller. We also had we have also examined this drug in another cohorts with AMD and pigment epithelial detachment. That was from the beginning a very interesting subcohort of patients to apply the drug to. This has already been published. This is one of very impressive images where you see the patient on the left-hand side. He comes in the consultation with an extensive PED, subretinal fluid. The patient starts the treatment with anti-VEGF, which is not working that really well. You see in the middle panel, you see the pigment epithelial detachment is still there. You see the subretinal fluid is still there. And at that moment, in the middle panel, we made the decision to change him over to brolucizumab. And take a look on the right-hand side, you see how smoothly the pigment epithelial detachment is getting smaller and the subretinal fluid is disappearing. One more study from Germany. This was I think, the very first one, at least in the European area. This is the REBEL study, a real-world study of brolucizumab. They had 78 consecutive patients examined with 105 eyes, both treatment naive and treatment switch patients. Both of the groups, they did gain in vision, plus almost 12 letters in the treatment naive group and plus 10 letters in the therapy switch. If you wonder about the ANEs, they only had one patient of a switch treatment that responded with a vascular occlusion, and he did actually quite well at the end of the study. This is one very interesting and representative case, as is shown in the publication. The panel D shows the state before anti-VEGF. The panel E shows the state post aflibercept and ranibizumab. You see how the pigment epithelial detachment is going up. You see a little bit of subretinal fluid, and the decision of the colleagues to change him to brolucizumab, how smoothly the pigment epithelial detachment gets away and subretinal fluid is also getting away, and how smoothly the retina goes down. One more study from Germany. This was the same REBA study as an extension. It goes up to 24 months. They also had exactly the same treatment protocol, treatment naive group and switch treatment. Both of the groups, they gain vision, plus 9 letters and plus 7 letters. And the retina went down smoothly anatomically for both groups, treatment naive and switch treatment. And they only had, from the 91 patients, they only have 5 significant unwanted events in their cohort. So as a take-home message from all this data that we have seen so far, brolucizumab is really working. It's very effective in stabilizing the retina and gives a sustainable result. It's a very small molecule. That's why it's working so good. It has been designed that way to give a higher molar concentration and penetrate the retina in a very good way. It is the only drug so far that has the fastest SRF resolution, and it leads to improvement of the vision and sustainable results. Many, many thanks for listening to me.
Thank you, Dr. Chronopoulos. What I suggest is we'll have more talks also, then we'll have a combined discussion. I hope you will stay on for, at least some time.
Yes, of course. Many thanks.
Yeah. The reason is because all of us will be discussing the clinical usefulness of this. I now request Dr. Indu, who again is a prolific user of Produsumab, and what her topic is breaking the barriers in the management. And what I understand, barrier to be broken is that you have to break your mental barrier, that you shift from shorter acting to longer acting. Is that so, Indu?
Good afternoon, everyone. Yes, sir. In 2000, that was the first time I actively started treating AMD with PDT. And where have we come now? We've come to such beautiful molecules, such potent molecules. So let's talk about this journey, breaking the barriers that we've had all through these 25 years. So yes, Hawk and Harrier told us that this is one molecule which is perhaps the most potent, but it was our real-world experience which really made us so confident that we know, yes, that is the reality. So the visual improvements which were achieved with brolucizumab were reaffirmed at week 96 also. They stayed the same, and it is non-inferior to all other anti-VEGFs there are till now. And we are well aware that there are superior reductions in brolucizumab as compared to all other things. Yes, of course, as we've just heard, it's the small molecule which is really making it more penetrable and also go till the area where the most of our AMD exists. So let's move straight to the real-world discussions. This is a 73-year-old female, CNVM, 624 vision. Now, this was the time when I was moving on from ranibizumab to a more potent molecule. Brolucizumab had just come. So this is about 5 years back. I've been doing OCT angio in almost all the cases. And in a single field, you can see there is a CNVM and there are polyps. And this is, we were trying ranibizumab, and with ranibizumab, one injection, the CNVM is gone, but the fluid remains. I was with my combined treatment of PDT and anti-VEGF, I was so used to getting fluid-free retina after these combined treatment, and I wasn't happy. So we ended up giving 6 injections of ranibizumab. This after 3 injections. The retina seems much better, but before, in about 4 weeks, the fluid would just come back again, and the fluid actually never left. If you see here in the IR image, the fluid is still there. This is after 5th injection of ranibizumab. This is 6th injection. The fluid just would come back. This is when we decided to give brolucizumab and see. After 6 months, this one picture when I saw, I knew we had come somewhere. We have achieved something. Now, this is a 56-year-old female, a patient of PCV. If you look at this membrane here, which is parafoveal membrane, the vision is very good, but we can see this membrane which is so aggressive, and the patient wanted to take bevacizumab, and we ended up giving 5 bevacizumab, but the membrane here is getting aggressive. So this is after the 6th bevacizumab. Now the fluid has also started coming, and the patient is scared. It is so aggressive. There are all signs of it going into the macula. This is when we decided to give brolucizumab. So this is before brolucizumab. See, the membrane is increasing. The fluid is increasing here. And this is what happens after brolucizumab. The membrane just kind of, it becomes non-aggressive. This is a 73-year-old female. When you are into a practice of doing OCT angios, there is not just one PED, but multiple PEDs there. So this is pre-injection PCV. If you look at this, there are PCVs and polyps, and this is after one injection of brolucizumab. It's all gone. 62-year-old female PCV. There are some small PCVs here, some large PCVs here, and with one injection of brolucizumab on to the right, you can see that, this is the only injection which has such a great effect on such huge polyps and PCVs. So 80-year-old female, if you look at this, there are so many polyps up there, and the PED is so huge that it is not coming even in the screen. And under the macula, there is fluid. With just one injection, the PEDs become smaller, the polyps have gone down, and macula looks, much better. A 45-year-old male. Now, we have Schramm hair, and with our experience of the older generations of anti-VEGF, we know there is no way we can take care of this Schramm. So, and we have lots of large PEDs and small PEDs here. So this is pre-injection. After first brolucizumab, this looks better. The smaller PEDs are gone. With the second injection, the macula is still better. The PEDs have become smaller. So this is pre-injection. Look at the Schramm here. It is better after first injection. It is still better after second injection. Pre-injection, OCT angio. This is after two injections OCT angio. So after the third injection of brolucizumab, macula is almost back to normal, and PED is so much smaller now. And after 4 injections of brolucizumab in the, after 1.5 a month, we give brolucizumab in these patients after about 6 weeks. And we can see that there is hardly any PED now. So another patient, 54-year-old female. Now this lady had the same minimally classic CNVM in both the eyes, and she was taking lots and lots of bevacizumab because she was so scared of losing that eyesight, but nothing was happening here. So after 12 bevacizumab injections for 1 year, she still had the same problem. It had not deteriorated, but then she had the same problem. And this is when we decided to make a change at the injection. You can see the edema here. And the same thing, this is pre-injection and post-injection. The first time in all these years, she had no fluid. And the same thing happened in the other eye also. A 70-year-old male. This is just to show that how important OCT angio is. I've been treating this person since last 15 years, and we've been able to keep his vision at 6/9, because on OCT angios, we are able to see any new vascularization or new CNVM which can come up, and we can keep giving injections, even if the line scan showing that everything is fine. So a 56-year-old male here. Lots of PEDs, and this is, the patient had heard that he just wanted to take ranibizumab, so we kept giving him ranibizumab, but nothing was happening there. After 2 ranibizumab, he had not improved, and this is when I asked him, would you like to change it to brolucizumab? And after brolucizumab, the PEDs are all gone, and he's happy. 75-year-old male, this is the first RPE RIP which I got with brolucizumab. After that, I haven't had any, thankfully, but just wanted to share this with you. This is pre-injection, this is post-brolucizumab, there is a rip here. The patient still had better vision. 70-year-old female, you can see the PEDs and, thick fluid there, post-brolucizumab, much better. 72-year-old female. Again, pre-injection, and this is post-injection brolucizumab. 57-year-old male. You know, this is pre-injection. You can see a huge PD, and on OCT angio, it has improved. 68-year-old male, a huge PD here, pre-injection, and this is how it works miraculously. 77-year-old female, this is another one, and pre-injection, this is post-injection. I'll now be showing you just a few treatment-naive patients where my first choice was, brolucizumab. I'm now giving this option to all the patients of CNVM. 77-year-old female, this is pre-injection. After 4 brolucizumab injections, this is how the patient looks. 30-year-old female, and there is the CNVM. And after 2 brolucizumab, the patient has recovered. 37-year-old male, 660 vision, and this is high myope, and this is a treatment-naive patient, pre-injection and post-injection. Most of these patients, they just require 1 injection. They get better. 73-year-old female, a CNVM, there is some fluid here. And after 1 brolucizumab, everything is just recovered. 40-year-old female, a CNVM. It's a small, fresh CNVM, and the patient decided to take 1 brolucizumab injection. It's all clear. 42-year-old female, this is, there are 2 PEDs, and there is this CSR element here, and after 1 injection, it's recovered. So it is actually, a huge, huge advantage that we are living in this era where we have this kind of a molecule. And after giving thousands of injections, I could continue showing you my results, but this is something which has to be taken seriously, because here we have, as a retinal surgeon, we have something in our hands which, there's no need to be scared of, actually, because in the last 2.5 years, I have not had any single case of IOI. So I think we all should at least try using this. Thank you.
Indu, for your vast experience. I think the largest number of injections, I think, you have used. We will quickly go through the last presentation, and then we'll have a exciting panel discussion. So, Chaitra Jayadev from Narayan Netralaya, heading retina services there, she will tell her experience, her center's experience with this potent anti-VEGF.
Good afternoon, everyone. My slides are pulled up. I just thought I will just add on what was already discussed so far. I think we've all had some experience with the previous molecules, and somehow I think the thing that we were lacking was durability of the molecule. By durability, I mean how long we can extend the duration between the injections. So with this, I would like to actually show what has been our personal experience and also our single center experience. Before that, I'll give a brief introduction about the molecule itself. I will try to skip slides that have already been presented so far by the previous 2 speakers. We do have an unmet need in neovascular AMD. We have an aging population, much higher than what used to happen in a decade or 2 before because of better healthcare. So let's look at what are the unmet needs. There are 3 different perspectives, one from the patient point of view, which I think we need to be extremely sensitive about. Of course, our perspective, the challenges that we face are also extremely important because we need to allay their fears, at the same time make sure that they get enough or adequate treatment. And then the healthcare perspective, which is more logistic, costing, access to healthcare, etc. So let's look at the patient's perspective. We know that it can cause severe and irreversible vision loss, and most often we see patients who are coming to us who are just one-eyed because they've not even realized that they've lost vision in the other eye. And since it affects the aging population over 65 years of age, their safety becomes a big concern. because they are prone to more accidents. So we need to be a little cautious about how we treat these patients. More than 90% of AMD associated blindness, at least in our part of the country, is neovascular AMD. In the West, we do see dry AMD. And in the developed countries, therefore, it's the #1 cause of blindness. And it's estimated there are about going to be around 288 million AMD patients by 2040. So this is the projected number across the different zones. Once these patients are diagnosed to have, they don't really come in regularly for a follow-up because of multiple reasons. One is, of course, the difficulty in traveling. Most of them have to depend on someone because of their decreased vision and their age. Next, they need to be ready to give us a commitment in time, not only for travel to the hospital, but also the various tests that are done. And if they undergo the injection the same day, then we need to do the procedure. So that takes time, and it's not only for the patient, but somebody who's also accompanying them. And finally, the frequent visits. So I think these are the ones that, besides financial reasons, which do not allow the patients to come. When you look at the physician's perspective, this was a study. Most of them said that the monitoring does take time, takes a lot of resources as well, and therefore doctors are also looking for a longer duration in between each injection to treat these particular patients. They also feel that the fluid resolution, I think, is not adequate enough, which makes us, keep switching between molecules. Dr. Indu also mentioned that, in a lot of her cases that she switched and the patients are doing much, much better. And as far as the wow effect goes for fluid resolution or resorption, it's been extremely good with brolucizumab. So retinal fluid is considered pathological, and its resolution is most important for neovascular AMD. We see different kinds of fluids here. This is the sub-RP fluid, subretinal fluid, and intraretinal fluid as well. So these are the different components, and we want resolution of all these different components of the fluid because that's gives us more stability for the disease besides even visual improvement. So retinal fluid is the leading indicator for activity through the progression. It also helps us in diagnosis, most importantly. The time to first treatment is also an important parameter. The treatment interval depends on how the fluid is resolving, and the visual outcomes, most importantly. Disease activity, definitely we base on whether there is fluid on the scans, whether there is visual acuity disturbance, and of course our clinical findings. And from the healthcare perspective, like I said, declining vision, obviously it adds to the societal burden, the drug cost, the treatment choices, the increasing prevalence, like I mentioned in the beginning, monitoring needs, OCT scans, the frequent visits to the doctor. And like I said, lifespan is improving, therefore the burden of the disease as well. So therefore, we are always on the lookout for something different, something longer benefit for our patients. And therefore, when I mentioned all these different factors, we also need to see what is the dosing regimen, whether it's been more frequent, less frequent for our different patients. This was already mentioned. There's a huge gap between clinical trials and real world evidence, and it shows that more than 70% of our patients are undertreated in the first year itself. And we already know that the initial treatment, how aggressive we are or how early we are in the treatment is extremely important. So this was the wide gap between RCTs and real world. You see the number of injections is so much lesser in the real world studies here. So the number of injections that are required to maintain visual acuity in the first year itself should be at least 5 or more, and more than 7.9 injections are required to improve vision from baseline of more than 15 letters in the first year of treatment. But this really does not happen in our practice, as we've seen, which is why I come to the drug that's been extremely useful in the management of neovascular AMD. It's an advanced single-chain antibody fragment. We've already spoken about the different advantages that it offers us. The affinity to VEGF-A is extremely high here. It has more VEGF binding ability per volume compared to the other available molecules that we have, and it also delivers more drug per dose because of its molecular characteristics. It has high retinal exposure but low systemically, therefore it's also good in terms of systemic morbidity. The elimination is also quite rapid, and these are the salient molecular characteristics that I told you about. It is small. Preclinical studies also suggest because of the smaller size, it facilitates better retinal penetration. High ocular concentrations are available, and each 6 milligram of brolucizumab delivers 12-fold higher molar dose than the other molecules. So now coming to the real life experience, I'm going to show you a couple of specific cases. This was a treatment naive patient, a 65-year-old female who presented with 6/24 vision. Here you can see a flat PD, regular PD there with intraretinal fluid and hyperreflective dots. So after the first injection of brolucizumab, you can see there's been good resolution of the intraretinal fluid there, and this was maintained even after the second injection. And so this is a quick comparison between pre-treatment and post-treatment. You saw a reduced PED there, the intraretinal fluid had resolved, and the intraretinal hyperreflective material also reduced significantly, if you can see in the scans. Now, this is a patient with recurrent subretinal fluid in PCV, 69-year-old with mild decrease of vision in the left eye despite the fluid there. The vision was 6/9. You can see here, this is we had given different anti-VEGFs in Jan and Feb, and the patient was lost to follow-up due to COVID, came back in Jan 2021. You can see there is again a recurrence of fluid there, and we gave an injection. 3 months later, again the patient came back. So with this recurrent SRF, this is when we wanted to think like, why don't we try Broly? And you can see this was on 19th, and by July 30th, since it was a new molecule, we called the patient back in 10 days to see the response, and you can see that the fluid has come down to half. That's extremely rapid response in 10 days, and this is at 6 weeks, and this is in December 21 after the second dose. The patient has maintained good vision so far. So inconsistent follow-up in this patient with recurrent fluid with suboptimal response, and after Broly, we were able to stabilize the disease. This is a persisting SRF in a patient. There's a solid PED. You can see the patient was started off with anti-VEGF 3 loading doses. The vision was 6/6 in this patient. So we're a little skeptical, how to go about treatment when the visual acuity is good. Of course, the patient does have discomfort or, metamorphopsia, but visual acuity is still 6/6 in this patient. So this was after loading dose. You can see in Jan, Feb and March, there was the resolution. I would say the PEDs also come down a little bit, but there's no, complete resolution despite the loading dose. Since there was persistent SRF even after the third dose, we went ahead with brolucizumab. This is in April. And you can see by May 21, 1 month later, you can see fantastic resolution. You can see even the PED has started coming down. So this is after the first, the second, and after that the disease has been stable. We've not had to retreat this patient so far. So good response to Broly after loading dose. We always wonder whether loading helps, doesn't help. It also is dependent therefore on the molecule here, because you see that the response was not great, but after we switched, it did improve tremendously. This is a 65-year-old gentleman, blurred vision for more than 2 years, multiple anti-VEGF injections already received. Here again, the vision was fairly good. So I'm just going to show you, this is a poor response to treatment for a recurrent disease. This was post PDT and anti-VEGF. Again, vision was fairly good, and we kept following up this patient, lost for follow-up again, unfortunately due to COVID. And you can see the recurrence is quite bad. Amount of intraretinal fluid, and you can see SHREM as well. So this is when we decided, let's try Broly. You don't, expect this kind of a response, but we were quite happy. This was a poor follow-up patient with multiple injections and acute on chronic, and good response of the intraretinal fluid to brolucizumab. Unfortunately, because there was a delay in treatment, the visual acuity improvement was not, as well as we had expected to be. Now, I think the biggest concern because of a rapid drying is, will we see a rip, especially in these patients with large PDs, which is why I wanted to show you this particular case. Again, scary because it's a one-eyed patient, already lost the other eye, already received multiple injections in the left eye. So this was a patient, again, you can see even the angiography is there for this patient. This was in 2020 when the patient was receiving bevacizumab. And then we again switched the drug because there was not great response. You can see some improvement there. This was, I think we've seen the patient last on 27 Jan, and the patient comes back in a month, and you can see there's a massive increase in the PD. You can see some subretinal fluid as well. And that's when we thought, like, now that we have some experience with Broly, why not try it? So the patient received the injection on 27th Feb, and this is on 6th March. It's just 1 week later. You can see how nicely the PD has started collapsing. The subretinal fluid also has started getting resolved. This is in 6th March, and by 20th March, 2 weeks later, the PD is further reducing. This was post the third injection. Disease we thought was quite stable, and we've been following this patient. So this is a large tense PD in a one-eye patient. We were little concerned whether to go ahead, but then we did get extremely good response with Broly. So just last few slides on our experience here. We've used about 926 injections so far. CNVM has been the most common indication, followed by DME, and out of these 30% of the eyes have been treatment naive. Post-treatment, the visual acuity is improved, the CSFT is reduced, and there's significant resolution of the PD, subretinal fluid, and intraretinal fluid. 3 eyes of them developed some IOI, and none of these patients have really lost vision when you compare it to the pre and post-treatment. Despite the inflammation, most of them have, 2 of them regained vision of 6/8 and 6/6 in this patient. No cases of DME in our series had any intraocular inflammation. So to summarize, yes, chronic CNVMs, definitely Broly is indicated with fresh activity for sure. Even tough tense PEDs, we have seen good response, persistent SRF, intraretinal fluid with hyperreflective material. We've also used it for flat and solid PEDs with recurrence and good response. Treatment naive cases, almost 30% of them. Non-response to anti-VEGF switch is definitely warranted, because there's great sub-RP response penetration. We also get good resolution of PEDs. Thank you so much.
Thank you, Chaitra, for this wonderful presentation. We can have Dr. Chronopoulos on this dais now, on this stage. Yeah, I suggest Chaitra and Indu, you can also join us here. So we'll have some discussion, and you see, all of you said various adjectives which I noted here. You see, beautiful molecule, potent molecule, great effect, works miraculously, miracle drug, wow effect, very useful, wonder. So the only thing which we as panelists, as chairpersons were thinking about is the treatment regimen and follow-up regimen. Chronopoulos, what is your treatment regimen, you see, with this wonder molecule?
Yes, for nAMD, we stick to the label of brolucizumab, which means we indicate 3 times every 4 weeks. And after that, we tend to, it depends on how the aggressive the treatment has to be. It depends on where we pick the patient up. But usually we start with 3 injections every 4 weeks. Most of the patients opt out for a treat and extend. I think this is what in the European area we are doing most, treat and extend, which is actually quite good. And we can tailor it down to the patient's needs.
Yeah, okay, thank you. I'll just ask the other panelists and chairpersons also. Indu, do you do same regimen, or what Chronopoulos said?
I give my injection every 6 weeks.
Every 6
if needed.
weeks. Chaitra?
So at treatment naive, I try to do the loading dose 4 to 6 weeks based on the response. If I'm seeing a good response at 4-week visit, I try to wait for a little bit more.
How do you follow up these patients? Like
4
you have given, so you have given injection today, you will call him after 4 weeks, or you will see
4
him
weeks. 4 weeks.
I follow up after 6 weeks.
straight away?
Yes,
Injection
straight
given
away.
on Monday, 1st April, then you come in mid-May now.
No, I always tell the patient to get a OCT scan done and send it to me. We have a huge counseling area where they keep getting these scans and they are shown to me, and then I decide. But then I call the patients after 6 weeks.
So, Chronopoulos, I think the posology has changed. I think posology most of the people do not advocate giving every 4 weeks. The reason I raise this question, there's no doubt in anybody's mind that it's the best kind of drying agent available today as far as anti-VEGFs are concerned. So, Praveen, what's your take on? I just want to know, you have given treatment today. How do you follow up?
That's what I would probably want to see the patient next day. In fact, for most my injections, though it increases the follow-up burden and all, but I think it's a good practice. Ask them to come the next day if possible, and then 7 days. So if it is, they are not able to come, at least show up with the local doctor or something, have a follow-up. And I think one good thing that we have learned with these injections is that we need to dilate them and see. Earlier we could just, do an OCT and follow up and see what is the response. But then now I think our practice or my practice is I definitely on the follow-up visit 7 days, I dilate the patient.
Is it only with this molecule or with all anti-VEGFs?
Seventh day visit is not there for all molecules, but for bolosozumab, I would prefer that they have a dilated.
Gopal?
Yeah, the VRSI study group has come up with 0.79% as the incidence of the adverse events. So I also, if it's a treatment naive, I will consider maybe 2 or 3 injections, but it is not fixed, like 3 injections should be done or anything like that. If the response is very, very good and the complete resolution of fluid is there, then I may wait. I will make a call to the patient at 1 week to see if everything is all right. I'll get my postgraduate to call that patient. And then at 4 weeks, the patient will come. Based on the OCT, I will decide if the OCT is completely flat, then I may wait a little longer and move more earlier to a treat and extend format.
I agree with you, Gopal, that if the OCT, especially PED, has shown a response and fluid, as Indu showed so many slides, has gone away, does your treatment, interval treat and extend use come faster, or you adhere to the same regimen that 3 doses have to be given and then you treat and extend?
The patients who are from the same city or around the city,
Forget about city. Is treatment
otherwise just they keep sending me OCTs.
Chronopolis, if the treatment response has come maybe after first injection, because I have seen so many patients, you see they will respond within the first dose.
Complete resolution of
Complete
fluid.
resolution with flattening of PED. You follow up the same regimen that you still give loading dose and then, or you treat and extend faster, earlier.
Yes, you mean, are you talking about the very first injection?
Yeah.
Just one injection?
Yeah.
Usually it's custom here that we do 3 injections. It's custom here. We do follow up the patients in regular time points, but it's on-label treatment, so we do use 3 injections at least, and then we proceed to treat and extend. But I give some right over there. There are many, not many, but a lot of patients or a lot of colleagues that do advocate just 1 injection and see how the patient goes.
So I want to add one point
Yeah.
on the follow-up, sir, because most of the patients find it difficult to come, follow-up. So treatment-naive patients, I think counseling becomes important to tell them the warning signs. We may not be able to follow up or call them up because of the numbers, but if you give them a list of the things to watch out for, post injections, most of them know what to expect, except for the first or second injection, they wouldn't know.
Is it out of fear of IOI or because?
Both, sir. It's not only IOI. See, some of them tend to have a simple floater and they'll come every few days till that air bubble goes away. So these are things what to expect and when to report. I think if that counseling is what we do, and we have our counselor's number on that slip where we've given the information, and an emergency number if counselor is not answering, they can call and they can come at any time. But I think that first time counseling becomes very, very important because these patients may receive injections for a lifetime.
I do the same, except that I, in addition, tell them that please close the other eye and see, because a lot of patients, you see, they are looking with both the eyes, they may not appreciate. So always tell the patient with the fist they should close without touching, and they should. And if there is a decreased vision or anything else, they should come early.
Another thing that you can always tell the patients is to either look at a calendar or a clock at home, because most of them say, how will I know that the vision has come down? They tend to see a picture and they may not even know. So simple is tell them to sit at a fixed distance from a clock or a calendar, look at a number, and then they'll know immediately if there's any drop.
Chronopolis, the time is not on our side because we have 5-7 minutes only. All of you have shown such miraculous effect. We'll start from Indu. Is it your number 1 choice today?
It
Be
is.
very frank and honest.
Yes.
Yeah.
In AMD, it is my number 1 choice.
So any patient,
yes.
if I come to you with the CNVM,
I'll give you the same counseling
Chaitra,
and
yes
get this
or no?
injection.
Yes or no?
No. It's not my only choice.
Chronopolis, what is your first choice in nAMD? First choice.
Yes, brolucizumab, not the only choice,
Brolucizumab.
but first choice is brolucizumab, yes.
Is it a difficult question?
No,
It
I
is,
think we in resistant case, most of the people
the reason
who have
Chronopolis,
shown their data, they have all shown that 60% were not treatment naive. So I think that speaks. Dr. Chetra's data also had 60% were not treatment naive. Even Chronopolis data
There are
did show.
multiple issues.
No,
So
the
there are
reason,
multiple
the
issues.
reason, the reason, let me be very clear, the reason I'm asking is, Chronopolis said low IOI. VRSA Gopal said 0.79%. Indu said, I have never seen a patient. And
In
all
the
of-
last
all-
2.5 years.
In last 2.5
Yes.
years. Chatra said she has seen 3 patients out of 926. So, and all of you also said that's the best kind of drying agent. Then why?
So, because there are other factors. So, we are not only talking about the efficacy or the safety. Affordability is always there. How many patients can afford
No, I'm
the
telling you,
molecules?
I'm telling you the drop which Chatra you quoted, na, that 70% patients are undertreated. The reason is the effect. You see,
Yes, sir, but-
I'm telling you,
Yeah.
even a poorest of the man, if he sees the effect, he'll come back. He'll come back.
No, I wanted to
If he
make one
sees-
point here. Even in the real world, in the best of the so-called developed countries also, the number of injections is about 2 to 3
Yes.
Yeah.
per year.
Yeah.
And that is very, very low.
Yes.
And that is a sure
what's the
shot
reason for that,
recipe
Gopal?
for loss of vision.
No, but what is the reason for that? It's not because it's not efficacious or it's not safe. It's because people can't afford the
It's a
molecule.
question of durability. It's a question of durability. You see,
absolutely.
if you calculate the economics of, with all the factors which all of you listed,
Yes.
cost, travel, all these things, and then you see durability, this economics goes for a 6, I'm telling you. It goes for a 6.
Now, another question which I wanted to ask the panel is that, how often have you seen patients who've been on treatment with some other anti-VEGFs? Now, you started on brolucizumab. You could stop treatment for at least 1 year or more.
I showed a lot of my
a lot of
cases.
patients.
A lot of
And also, once the patient is on brolucizumab, I've had a few patients who went to another city and were told there is a better molecule that's faricimab, so why didn't you try that? All those patients who were under treatment with me from brolucizumab took 1 or 2, the second injection, faricimab is free, so they took 2 injections, came back to brolucizumab.
I have
They
also,
all tend to leave faricimab
So there
once.
is no controversy where the efficacy of brolucizumab
Yes.
is
no,
concerned.
the question Chronopolis I was asking was, which Dr. Praveen Sen actually provoked me to ask, is when to stop. Suppose, you have had good drying for a long time. Do you consider stopping treatment nAMD? If yes, what percentage?
Yes, of course. We have a lot of patients that are in the treat and extend protocol, and they reach up to 12 weeks, 8 weeks, 10 weeks. After that, I consider stopping, depending on the anatomy is okay and how the patient is responding. But I don't expect the patient to have a lifelong treatment with brolucizumab. We have a lot of patients that have received just 7 injections per year, and that's it. But it's not the same as diabetes. I mean, you have to check the patients every now and then to see how the lesion is responding. But yes, we do stop it.
And the last question is, you see there have been a lot of apprehensions in the West meaning US. US, whatever data I see on the net, their usage is much less, although it is picking up there. Whereas you see Germany, Korea, Japan, India, Southeast Asia, Pacific, there is a huge percentage of retina people who use brolucizumab, maybe treatment naive as well as switch. So what is the reason? Because a lot of people, copy the West. Why can't the West, look at the experiences of
Yes.
so many other?
It doesn't show up in the questionnaires. If you look the PAT survey, for instance, the brolucizumab is a very small percentage. In some questionnaires, they also leave it out, they also completely omit it. I agree with the colleague that said that many patients of Vabysmo, they would like to switch over to brolucizumab, if I understood your comment correctly. And I do understand there is a bit of apprehension at the beginning because of the drama that we had 2019, 2020. But to be honest with you, I have seen just in the last 5 years, just 2 patients having an IOI, a very smooth one, a very mild one that recovered. They recovered quite nicely, and all the other colleagues that you brolucizumab, they cannot confirm those big numbers.
I think the
That's
reason for
it.
increased use of brolucizumab in Asian population is also increased incidence of PCV. And PCV,
Yeah.
I think a lot of
Is
other
one of
drugs,
the-
they don't work, and this one works better. So
Yes,
there is
indeed.
a
I
natural
confirm that.
tendency to use it more.
Absolutely. I think PCV, PEDs, it works. So I think time is, we'll just conclude this by 1 or 2 lines saying that it is a wonder molecule, it's a best drying molecule, and it's a faster, there's no doubt about it. And all the compartments are taken care of. It's not only IRF, which is the most deleterious, but even SRF and even sub-RPE compartment. And You see, we all started with unmet needs. We keep talking for, for years and years. First slide, everybody says unmet need, unmet need. So needs are met now.
Yes.
So needs are met now. So there's no confusion in a lot of people's mind that even like Praveen was saying that PCV, for number one choice, PED, I have never seen flattening with any other molecule. PED absolutely disappears. And fluid collapse, whensoever you see Indu was saying, ranibizumab, so many injections given, bevacizumab, fluid. PCV, CNVM gone, but fluid still there. So here is a molecule which dries up everything. So I think all of us should, all of us should collate our experiences and present a huge data so that this fear of IO has somehow to go away. In Indian subcontinent, this fear should, decrease.
Yes.
Because this fear is unnecessarily dictated by the first insert they had, 4.6%. In fact, I was jokingly telling them, have you forgotten 0 point? Because it's actually much, much less.
Yes.
So with this, I'll thank Coronapolis and all the learned speakers here and all the panel. Thank you very much for joining this webinar.
Thank you.
Yeah.
Thank you very much.
You
Bye-bye.
you be on the line because we are going to take a picture from the TV itself. Don't go away. Can we have Chronopolis there? Band nahi karo. Let him. Yeah, please hang around for a second. Thank you, Chronopolis. It was nice listening to you. Okay.